Hey, David.
Hey,
Hi.
Dr. Coleman, how are you? Professor
Great.
Dubois. Professor
Hello.
Dubois, it's an honor to have you with us.
David, that hair's getting long.
You know, we have quarantine. There's no hair cutter.
I know. I actually had my wife cut mine last night.
Uh,
I love it.
Here in Mexico, we have the same issue, and my mother cut my hair a couple of weeks ago because
Yeah,
there is a place
my wife as
for a
well.
haircut.
I love it. Mm.
So
Great to see ya.
we are ready to start in order to finish on time, because I know you all are very busy and your agendas are extremely crowded. And I want to welcome Professor Dubois for this session, as well as Dr. Robert Coleman from MD Anderson. And it's an honor for us, for all the group at INCan Mexico, to have these two distinguished professors in our annual session of the topics in gynecologic oncology 2020 in the scenario of the International Academic Oncology Meeting of the Instituto Nacional de Cancerología in Mexico. Muy buenos días a todos, sean ustedes bienvenidos a nuestra sesión el día de hoy. Es un honor para nosotros tener al doctor Dubois y al profesor Coleman en esta sesión del Topics in Gynecologic Oncology del año 2020 en el marco del International Academy Oncology Meetings del Instituto Nacional de Cancerología. Y para empezar y no hacer más largo el preámbulo, presentaremos dos sesiones, la sesión del doctor Coleman, la sesión del doctor Dubois, y después tendremos una sesión de preguntas y respuestas donde esperamos que todos ustedes, por medio de los comentarios en la página de Facebook, nos hagan llegar sus preguntas y poder así compartir con ellos nuestras experiencias y que ellos nos compartan toda su experiencia en el manejo del cáncer epitelial de ovario recurrente. Empezamos entonces. We start now.
Okay.
El doctor Robert L. Coleman realizó sus estudios universitarios en matemáticas y posteriormente en medicina en Creighton University. Realizó la especialidad de obstetricia y ginecología en Northwestern University Medical Center y la subespecialidad de ginecología oncológica en the University of Texas MD Anderson's Cancer Center. Actualmente es profesor de Departamento de Oncología Ginecológica y Medicina Reproductiva y director ejecutivo de Cancer Network en the University of Texas MD Anderson Cancer Center. Codirector de GOG Partners Philadelphia, board member del MD Anderson Physicians Network y presidente electo de la International Gynecologic Cancer Society IGCS. Ha recibido premios como The Best Scientific Presentation por la Society of Gynecologic Oncology, SGO, The Clinical Oncology Fellowship Award por la American Cancer Society, entre otros. Es miembro de la Junta Directiva y embajador de Gynecologic Cancer Foundation en Chicago y de distintas sociedades como APGO, ASCO y AACR. Ha escrito más de 300 artículos de investigación originales y elaborado en más de 150 artículos reconocidos a nivel internacional.
Very nice. Thank you. Thank you, everybody. I hope everybody can hear me well. I'm in. It's great. Again, very grateful to join you today, and thank you so much for the invitation. Excuse me. We'll be talking about surgery and chemotherapy for recurrent platinum-sensitive ovarian cancer, and I'll start us off by presenting GOG 213, and then Professor Dubois will do review desktop 3, and then we'll have some discussion for these really important trials. Excuse me. These are my disclosures. So I think that most of us realize that the platinum-sensitive space for ovarian cancer has evolved tremendously, from single-agent chemotherapy to combination chemotherapy with various adjuvants. And in 2020, that adjuvant is largely now dominated by the use of either anti-angiogenesis drug bevacizumab or a PARP inhibitor. Since most of these patients do have chemosensitive disease, the thought is that secondary surgery could play a role, since many of these patients have long disease-free intervals and do respond to chemotherapy again. And this has been one of the tenets for which surgery has been considered, since we do the same approach in the frontline setting. And there have been about 600 publications that have been dealing with the issue of surgery in the recurrent setting for ovarian cancer. Despite all of the retrospective data, there's been a number of issues that have come up from these studies that have raised questions of ascertainment bias, certainly selection bias, and every one of these papers tends to come up with a comment at the last paragraph that says randomized trials should be done. And we've responded as a clinical community, and you can see here there's 5 randomized trials that have been initiated to try to address the role of secondary cytoreduction in ovarian cancer. One of these has completed and is published, GOG 213, which you're going to hear about today. Desktop 3 and SOC1 were 2 completed trials that have been presented. And 2 of these trials, one, the RTC trial, actually closed for futility several years ago. And the second one is looking at PFS as a primary endpoint. And the reason I've highlighted these 3 with OS endpoint is because we felt that this was an important endpoint to be addressed in a prospective trial. Now I'm going to give you a little sneak peek of what these trials show, the 3 that we'll be talking about today, 2 in detail. And you can see the curves generally look kind of the same. The problems are that they don't provide the same message. And you can see at this third line here that the hazard ratios go in different directions, with one of these being significant, which Andreas will talk about in a second, and the 2 others for OS being not significant. So GOG 213 was set up many years ago. Actually, the first iteration of this trial was first put to pen to paper in 1999. So almost now more than 20 years ago. It was actually formally launched in its current form in 2007, and it had 2 primary objectives. The first objective was to evaluate the role of adding bevacizumab to paclitaxel and carboplatin, followed by bevacizumab maintenance to increase overall survival in patients with platinum-sensitive recurrent disease. The second primary objective of this trial was to evaluate the role of secondary surgical cytoreduction in patients who were good candidates for surgical cytoreduction. So it was a randomization of surgery versus no surgery. And then patients were allowed to go on to adjuvant chemotherapy, with the primary endpoint being of overall survival. So both of these were overall survival, and they were considered independent endpoints. So this is the objective for the trial as it was launched for objective 1. You can see that as part of the eligibility, patients were enrolled onto the trial. If they were considered surgical candidates, they were then randomized to surgery versus no surgery. And in the initial launch of this trial, you can see there was about a 1-to-6 ratio for patients going on to the surgical randomization. In all, there were 674 patients enrolled into the trial, with the primary randomization for chemotherapy being Bev versus no Bev, with Bev maintenance. So you can see that patients that went into surgery in this part of the trial were randomized twice, randomized to surgery and then randomized to chemotherapy. The primary objective of this chemotherapy portion of the trial was overall survival, and you can see here that there was about a 5-month at the median, with a p-value with a hazard ratio of 0.823, which was considered significant. So in the second objective, we decided to proceed to evaluate the role of surgery as a process to increase overall survival. So you can see that the randomization is only for surgery, and then physician choice was allowed, since we had already proved at that point that bevacizumab was an important addition to chemotherapy. And of course, this fell after gemcitabine, carboplatin, bevacizumab was approved already for this setting. So in light of that, we allowed for to either paclitaxel or gemcitabine to be added to carboplatin, and then allowed for bevacizumab to be given during chemotherapy as maintenance per standard of care in the United States. So secondary objectives were to look at progression-free survival, quality of life, and then the entire data set is going to be interrogated for a number of translational endpoints. That making it over 1,000 patients that will be available for that kind of evaluation. So in terms of eligibility, patients needed to have a complete response to frontline therapy, and that could have been assessed by, had to be assessed by exam and CA25. If they had a reassessment surgery, they had to have a pathological complete response. Maintenance therapy was allowed, and prior bevacizumab was allowed. Now, the platinum-free interval needed to be a minimum of 6 months. And if maintenance was administered, then recurrence needed to be after 6 months from the last treatment. Recurrence was documented as either clinically evident, which is measurable or assessable, but any equivocal disease needed to be confirmed by biopsy. The ineligibility were that they had received only more than one prior therapy, excluding maintenance, and then other issues that would be poor risk factors for surgery, such as need for TPN, bowel obstruction, and then issues with chemotherapy, so grade 2 or more neuropathy, hypersensitivity, major surgery within 4 weeks, and then the estimated inability for a complete gross resection. So as far as the trials was developed for eligibility for surgery, the assessment was made through candidacy that was based on physical exam, laboratory studies, and imaging. So allowed for PET, MRI, PET CT, or CT. The guidance in the document was that patients must be amenable to a complete gross resection, and that meant that there needed to be no evidence of carcinomatosis, clinically relevant ascites which required paracentesis, and extra-abdominal parenchymal organ disease, such as lung or bone. If there was parenchymal intra-abdominal organ disease or peripheral nodal disease that was felt to be completely resectable, then those patients were allowed to participate on surgery. But if they had disease that was otherwise considered an inability to complete gross resection, they were not eligible for study. The statistical design, this was overall survival. We assumed no interaction between the two randomizations, so we can come back to that point later. Alpha was set at 0.05 for each of these variables, consider their independency. And for this particular portion of the study, platinum for interval and chemotherapy chosen were two stratification variables. We looked to achieve a hazard ratio of 0.7, which amounted to a increase from 50% at 22 months to 61.5% at 22 months. And the analysis was to be considered mature at 250 events. So keep an eye on that. So the trial was open in 2007, took 10 years to complete the enrollment. You can see that patients were enrolled from the GOG participating sites. The Korean GOG did join the study during the middle of the, essentially after the randomization for chemotherapy, and contributed a number of patients to the trial. You can see their studies were well balanced with low levels of crossover and protocol violations. Now, this is just the patient characteristics, and I just highlight the yellow where patients were coming from. So these were generally 50 to 70-year-old patients. We had a significant contribution from Asia, about 46% of 7% of the patients from there. They were mostly serous grade 3s, and you can see that bevacizumab at the time of this trial was contributed to about 10% of the patients in the trial. The chemotherapy regimens are listed here. As I mentioned, it was paclitaxel, carboplatin plus, or gemcitabine, carboplatin plus minus bevacizumab. You can see that there's a heavy predilection for use of bevacizumab, accounting for 84% of the total patient population. And the most commonly used regimen for this in the adjuvant setting was paclitaxel, carboplatin, bevacizumab, with nearly 70% of patients having that. When we look at the time to initiation of therapy, you can see it was substantially longer in patients who had surgery, as you can imagine, for recovery. But if you look at the platinum-free interval amongst the patients, there were about 20 months between the two groups, and not significantly different. Now, one of the things that we'll talk about is patient selection. So surgical, per this study, based on the use of investigator choice and the guidelines I mentioned, the clinical guidelines I mentioned, there was a complete gross resection rate of 68%. And at the time that the trial was initially reported, we had about a 3-year follow-up period. Now, there's a lot of confusion about DSMC, but I will say that in the analytical plan, there were 2 scheduled futility assessments that were put in as part of the randomization. And the first assessment was to be done when there was 50% of the events being recorded as death. So in July of 2017, based on a data lock of May 2nd, there were 52% of the informative events had happened. Excuse me. At that time, the Data Safety Monitoring Board requested that 6 additional months of therapy be added, or events be added to the database to reevaluate a trend in their observation for the primary endpoint. And at that time, in November, we locked the database again, and we had 60% of the events, the informative events at that time. And what their guidance was to us was that based on this being a superiority trial, the likelihood that we would meet our 0.70 hazard ratio was exceptionally low. And you'll see why here in a second. But they said that the conditional power to achieve of 0.70 was less than 1%, actually at 0.1%. And so they felt that the additional events would not change the result of of this analysis, and they allowed us to release the data to the patients and to the participants. Now, as part of the publication plan, New England Journal of Medicine requested that we update the data lock to April. At that time, we had about 80% events in the trial, and so that is what I'm going to present to you today. So here's the primary endpoint of the trial of surgery versus no surgery. The red line represents no surgery. The blue line represents surgery. The hazard ratio was 1.29 with a 95% confidence interval of 0.97 to 1.72. So you can see with the Data Safety Monitoring Board seeing a preemptive look at this, that there was very little chance that this curve would be completely flipped in the opposite direction to meet our 0.70 hazard ratio. The median was about 15 months or 14 months different between the two groups, but the hazard ratio was 1.29. There was some criticism as well. This included Korean patients, so we pulled those patients out and looked at the hazard ratio amongst US patients only. This really didn't measurably change anything because the complete gross resection rates were the same between the two organizations, but the hazard ratio was 0.92, and you can see the hazard ratio, the 95% confidence interval. So for secondary endpoints, we looked at progression-free survival, knowing that progression-free survival will be dependent on measurable disease, and if patients go to surgery, they will have their measurable disease resected. So you can see that the hazard ratio was 0.82 with the upper limit of confidence about 1.01, so very close to being significant, amounting to about 3 months difference on at the median. Number of subgroups were looked at, and these are in the manuscript, which you can look at. There are several hypotheses questioning things that we could address. But in general, all of these subgroups appear to be aligned with the primary endpoint of the trial and the confidence interval around that 95% confidence. So a number of points, it was very consistent. Now, we were interested in knowing how patients who had a complete gross resection did. So this analysis is only for surgery patients. And you'll see that patients who had a complete gross resection did better than patients who did not have a complete gross resection. This is for progression-free survival here on the left and for overall survival on the right. And you can see what the hazard ratios are, 0.51 and 0.67. So a patient who's taken to surgery who does not have a complete gross resection does do worse than patients who have a complete gross resection. Of course, this would make sense particularly for progression-free survival where the greatest difference is seen. However, when we looked at this versus chemotherapy, so just chemotherapy alone, so you can see there's a difference in patients who had a complete gross resection and chemotherapy versus those who just had chemotherapy. But when we looked at the effect on overall survival, what you can see is that while the curves are now narrower, more closely together, that there's really no difference, again, between the surgery and the complete gross resection patients and those that just got adjuvant therapy. So in this respect, we didn't see any benefit to complete gross resection versus an all-comer population who had just chemotherapy. We looked at the side effects because we were really concerned about that. What we found in many of the studies have shown that surgery in the setting is safe. Most of these patients have more limited disease than in the primary setting, and so we saw that there was very little difference between these subgroups because there was a large number of use of bevacizumab. There were several bevacizumab-related toxicities that were seen, but they were balanced between the two groups. So there wasn't any additive effect for surgery, with particular attention placed to GI side effects, which were very uncommon, as is our experience with bevacizumab. Now, when we talk about these trials in concert, you can see they're listed here. SOC1 we haven't presented yet, but it was also a trial that was done looking at the role of surgery versus chemotherapy. Surgery plus chemotherapy versus chemotherapy, and the data on overall survival endpoints are presented here. And as I mentioned, these curves look, they have a similar morphology, although the randomization arms are a little different. So I did a little trick here to try to provide some context with this. And if you look at this, in the SOC1 trial, the blue line represents surgery, the red line in desktop 3 represents surgery, and the blue line in GOG 213 represents surgery. So if you overlay these, what you see is that and this is a combination, what you see here is this outlier line here is the chemotherapy arm of GOG 213. These 3 lines in the middle are the surgical arms for each of the 3 trials. And it basically reflects the median outcomes, as you can see, between these 3 trials, which are very close. But it's not just the median, where there can be some unstableness of the graph. It's through the entire exposure. So these surgery arms are actually really close to each other, which is remarkable that they're so aligned. Which basically shows a very consistent effect of surgery. And I think it'd really be interesting as we do more work on this to understand how this is. Now, it's important to understand that these surgical patients are actually very sensitive to chemotherapy. So the question is what's playing a more dominant role? It's not that they don't have effect, but what's playing a more dominant role? And so I'll leave you with this last final point, and that's that, you know, adjuvant therapy that includes bevacizumab has already proven to improve overall survival. So this adjuvant therapy, if it's not controlled for, could potentially confound the outcomes of the trial. So what I did is I took some data in our supplement, and I wanted to see what would be the effect of bevacizumab on the surgical patients. So what you're viewing here are the surgical patients who got bev and the surgical patients who did not get bev. And what you can see here is that there is a very large difference in patients who were randomized to surgery but did not get bevacizumab. So very unusual. Now, of course, this is a very small subtotal. So it's only 38 out of the 240 patients. So I wouldn't make a lot of in there, but it does say, at least in 213, that there was some difference between the patients who went on to surgery and did not get bev. Now that was left to physician's choice, and I don't know what those factors were. So I don't want to make too much out of this, but it was very interesting that there is this potential observation. And I'll just add to the story that, you know, adjuvant therapy today in 2020 is changing. Now we have drugs like the PARP inhibitors, which are adding even more of an alteration in the adjuvant, a benefit in the adjuvant setting. So these are very important to when we consider the role of surgery versus no surgery, when we have so many options for adjuvant therapy that could influence an overall survival endpoint. So in conclusion, secondary selection was not, in this study, was not associated with an improvement either in PFS or OS. The optimal complete gross resection rate was 68%, and that was similar to desktop 3, which you'll see here in a second. We did see that in surgery patients that complete gross resection was far superior to non-complete gross resection, which places a premium on selecting patients You want to definitely make sure that you can do that. However, relative to chemotherapy alone, complete gross resection was not better than patients who just had chemotherapy. So adjuvant therapy matters. I wish I had a mask. I could say, you know, that's big in this country. Adjuvant therapy matters. And I think that the rates of adjuvant therapy do need to be looked at in total in trials that look at overall survival, since many of these patients will receive 4 or 5 or 6 additional lines of therapy after surgery. And that will definitely potentially impact that overall survival endpoint. So thank you so much, and I'll stop there.
Thank you, Dr. Coleman, for your very interesting presentation. Now we move on with the other presenter, which is Professor Andreas Dubois.
El doctor Andreas Dubois realizó sus estudios universitarios en filosofía en la Freie Universität Berlin y posteriormente medicina en University Freiburg. Realizó la especialidad en obstetricia y ginecología y el doctorado en University Freiburg. Actualmente es director del Departamento de Ginecología y Ginecología Oncológica de Kliniken Essen-Mitte, KEM, y profesor asociado de la Universidad Mainz. Ha recibido diversos premios y honores como Honorary Member of the Russian Society of Gynecological Oncology, Deutscher Krebspreis, MD Anderson Madrid Lifetime Award, entre otros. Es miembro de distintos comités y sociedades como ASCO, ESGO, ISGC, German Cancer Society y AGO. Tiene más de 500 publicaciones en revistas indexadas y múltiples invitaciones y ponencias en eventos reconocidos a nivel internacional como en ASCO.
Many thanks. So you're very nice. So first, congratulations to the excellent presentation of GOG 213. Rob, you made a great job, but I will put some spice in that now. So thank you for invitation to this conference, and I'm far away from you, as you can see. It's almost 10,000 kilometers and a long way to travel, but easy by a virtual meeting. So this is one of the advantages, that we can easily have these conferences in that way. However, I would prefer to meet all of you in person, and I hope that this pandemic ends one day and we are able to meet again.
We hope so.
I'm talking. Yeah, now I'm talking.
So, we would like to have you here in Mexico sometime.
Oh yes, I would love to come. So, but now I'm telling you the truth about surgery of recurrent ovarian cancer. So this is my disclosure. So surgery is a mainstay of ovarian cancer therapy and probably one of the most mightiest weapons. I agree with Rob that chemotherapy systemic treatment is very important, and it becomes even more important when we develop more and more lines of treatment. However, surgery is one of the most mightiest weapon when you look at the data in primary, and I will show you in recurrent ovarian cancer. It can cure early stage of disease. It can prolong overall survival and has tremendous impact on prognosis that have been observed in meta-analysis of clinical trials and in other meta-analysis of centers and study groups. And it's one of the only prognostic impact we can improve by therapy. So quality of surgery matters. Here you can see our early learning curve when I took over department in more than 10 years ago, and we could, and in that time all systemic treatment was the same. It was carbotaxol for all patients, and you can see by improving the surgery you can improve survival. So why shouldn't it work in recurrent disease? So this is Rob says a tenant. I say it's a belief. and we have to prove it. And that was the reason why we started a series of trials on that in parallel to Rob and the Chinese group here in Germany and Asia. And that was the desktop series. We started more than 20 years ago with desktop 1, where we tried to figure out what could be the right population for a surgical trial, because we would not expose patients to surgery who in the end would not benefit from it. So we found in our first series, we found that only complete resection, it was associated with a prolonged survival and not resection to small residual disease, which was at those days believed to be optimal surgery. But that was not true for recurrent ovarian cancer, and that was later confirmed in meta-analysis as well. We also developed a score which could identify patients with a high probability of achieving a complete resection later on. So that was a population we believed would be justified to be randomized and recruited into a surgical trial to avoid exposing patients to surgery who would not benefit from it at all. And that score, which was developed as a hypothesis in the retrospective desktop 1 study, was then taken to a multinational prospective trial and was confirmed. So here, this was the first trial ever in ovarian cancer surgery evaluating a score prospectively and proving that the score works and does what he should. This was not a score to identify inoperability, but only a score that was developed to identify a population suitable for a surgical trial. So then we started this trial in parallel to GOG 213. The Chinese trial came a little later. In the beginning, the Chinese and Korean group were part of our trial, but then they split off and developed a slightly different selection criteria for patients and started their own trial. So in the beginning, they were part of that. So we took patients with first relapse, at those days called platinum-sensitive disease. They all had a positive selection score. That means they were platinum sensitive, they had a good performance status, they had only minimal amount of ascites, and they had an initial complete debulking surgery. That was the score. And the centers participating in that study were also selected by their surgical quality. Most of them had qualified, the German centers as well, at least have qualified through the LINE trial and the desktop 2 trial, where especially in the LINE trial, we had a very rigorous quality assurance system. So patients were then randomized to surgery or no surgery, and both received the same platinum-based combination therapy thereafter. More than 200 patients per arm, and you can see that there was no significant difference with respect to patient characteristics, and pretty much the same as in the GOG trial. The majority had high-grade serous cancer. Almost all of them had prior platinum therapy. The majority had prior taxane therapy, and the majority had more than 12 months platinum-free interval before they joined the trial. The complete resection rate was 74.2, so roughly 75%. So 3 out of 4 patients randomized to surgery then received a complete resection. We had a very low mortality, perioperative mortality in 30 days 0, 90 days 1 patient, and that confirms that we selected the right centers who are capable and competent in doing such kind of a surgery, and the right patients who could tolerate the surgery that was necessary to remove the tumor. That was what I reported at ASCO 2017 when we had our planned interim analysis, which was in the statistical report. and was also planned after half the events in the overall survival, but with mature events in progression-free survival. And in this analysis, we could already show that complete resection really makes a difference. We have here in green the no surgery arm, in red the surgery but with residual disease, and in blue the arm with complete resection. And what you can see is that there is no devastating effect even if you have a non-successful surgery in these patients with respect to PFS. But there is a tremendous impact if you have a complete resection. So what happens thereafter? Patients receive their platinum-containing therapy. Very few received the non-platinum combination. Bevacizumab, in contrast to the GOG, was only given to a minority of patients, roughly 1/4 of the patients, and PARP inhibitors at those days were only available in some studies, so only very few patients received them. Surgery for second relapse or higher was done in almost 10%, which is also a small minority. We did not talk about it, but in the Chinese trial, this goes up to 40%, which could later dilute overall survival analysis. So this was this year's ASCO, and this year's ASCO and the publication, which is in submission. The primary endpoint of desktop 3, the outcome of the first endpoint, overall survival in the ITT population. And as you can see here, there is a clear, significant impact of surgery on overall survival, with a median OS gain of about 8 months and a risk reduction of 25%, which is a clear outcome in this trial. So when we compare patients in the surgical arm only having a complete resection or an incomplete resection with a residual tumor, there's a tremendous difference between that. You can see here almost 3 years difference in median overall survival, underlining that it is absolutely important to achieve a complete resection if you want to provide some benefit to the patient. And this is the clinical trend, the clinical scenario when we talk to patients. So when patients come here with these recurrent ovarian cancer, we check them if their AGO score is positive, which is true in about 50% of patients. And then we tell them that the chance that we achieve a complete resection is 3 out of 4. This is 75%. And if we achieve that, then the benefit we could estimate is a gain of overall survival of more than a year, or a risk reduction of 40-something%. So that is what we're aiming at when we talk about the patients, knowing that 1 out of 4 will not end up on this curve, but will not have a complete resection. But that's in all therapies, so it's the same in chemotherapy. Some patients do respond, others do not respond, but you're aiming at the response in all the patients. And that's true for BEV, and that's true for PARP inhibitors as well. So this has been shown at ESMO by Fabrice Lecoureux, and this is time to first subsequent therapy by surgical outcome. And again, here you can see no devastating effect if you have a incomplete surgery, but a benefit only if you have a complete resection with respect to time to first subsequent therapy, which is usually another chemotherapy. And so we are only aiming at this. There's no role for doing a surgery when you have any suspect not achieving a complete resection. So, and this is an analysis in a very small subgroup of patients. These are patients who had been randomized to surgery but never received the surgery due to they were withdrawn or they had some other impact which did not allow surgery at those. And you can see if patients having had the randomization to the surgical arm but not receiving the surgery had the same fate than patients having a residual disease. So the surgery itself did not reduce the overall survival of the patients. So this confirms that we can do this. Also, we do not achieve a complete resection in all patients. However, a benefit, and that's what we should aiming at, is only achieved with a complete resection, and we should at with any effort try to avoid putting patients here on the green line. So how to decide now if you have two seemingly contradictory trials? Look at the methodology, design, control for bias, quality of trial performance, robustness of statistical analysis plan, compliance with SAP, reliability and legacy of the trial, or the credibility, the beauty and brains of the presenter. And as I said earlier, then Rob wins all the competitions. However, I will put a little spice on that by going into some of these details. So first of all, when we look at the trials, which is a great trial, there's no doubt it's a great trial. However, this is a great trial for bevacizumab. And the centers primary were not selected for surgical competence, but for being able to run a bevacizumab trial. And if you look at this is true when you look at the hyperselection. Only 16% of the original patients for the bevacizumab part were randomized to surgery, and only very few from Korea and Japan in that. So after bevacizumab was done, then come Korea and Japan and completed the trial. And some of the centers then had a different selection criteria, obviously, and then completed the trial, which was changed a little bit due to what Rob already said, due to that bevacizumab combination becoming the standard in the US. So Rob always said GOG was not terminated early, and that's true. I mean, it was fully recruited, and it was not terminated just for fun. I mean, the IDMSC suggested to do that, so everything goes according to protocol. But why? All the patients had been recruited, so there was no reason, no safety reason not to wait until you have the mature results. So what happened 2017 and motivated GOG to do this futility analysis, which is very unusual because, I mean, why are we doing randomized trials and fulfill the statistical analysis plan and wait for the maturation of data when we could solve everything with futility analysis? Why then do a randomized trial? However, Chuck Berry died. I mean, this is really a great loss for musicians like myself, and Rob is a musician as well, I know. Chuck Berry is one of the most influential musicians in the past 100 years, but Chuck Berry has nothing to do with GOG 213. The UK started negotiations of Brexit. That has nothing to do with GOG 213 or desktop, because in the UK, there's not a big thing with surgery. What happened 2017? Oh, AGO presented our interim analysis, and it looked as that we can get a little quicker than GOG. And Donald Trump was elected 45th US president, saying that from now on, America should be first in everything. So also in recurrent ovarian cancer surgery. So just try to imagine, would this debate even exist if desktop was a positive American trial run by the GOG, well designed and performed according to the statistical analysis plan and based on the legacy of a series of trials answering the question of surgery in recurrent ovarian cancer. And on the other hand, GOG 213 was a German or a non-US trial with terminated follow-up due to an unplanned futility analysis performed in centers without selection criteria and quality control for surgery. Wouldn't we then ask what went wrong with GOG that they failed to confirm desktop and observed such an outlier in the non-surgical arm? Wouldn't the question then be, why is GOG negative instead of why is desktop positive? I mean, you in Mexico have the same experience with your cervical cancer trials, which were accepted all around the world, but not in the US. So, Rob tries to explain it with systemic therapy, and he says, don't underestimate systemic therapy. And I fully agree. He was talking about PARP. However, when we are talking about PARP, we're not talking about overall survival so far, but we're talking about PFS. Then he was talking about the role of bevacizumab and says bevacizumab has a proven impact on survival. I can't see that so far. The two trials he cited, one is his own trial, the GOG 213. In the ITT analysis, this was not significant. It was only after adjustment and so, I mean, a little bit not so convincing. And the other trial he pointed out as significant is our trial from the AGO, but in this trial we compared two bevacizumab regimens. So this is not a trial evaluating bevacizumab, but it's a trial evaluating the chemo backbone, which we should combine with bevacizumab. And then it was significant. So why is GOG 213 negative? That's a question to be answered. Does bevacizumab replace the impact of surgery? And now I tried really hard to find out how that works with Rob how that works out. What Rob is brilliantly doing, namely moving curves to one each other, and I found out the way. So this is GOG 213, the subgroup analysis of patients with and without bevacizumab, and then surgery or not. And what you can see here is that there is one outlier, and this outlier is patients having had surgery but no BEV. And this drives the whole trial negative. So what we could conclude out of that, also it's a small subgroup and we should not put too much on it. But if at all, we should conclude that bevacizumab should be given after chemotherapy together with after surgery together with chemotherapy to avoid such an outlier. So putting all three slides together, besides bevacizumab, which clearly is a difference, there are maybe other difference as consequence of different selection criteria. The AGO had very strict criteria. The Chinese group had also strict criteria, but allowed that the investigator himself could break the rules, or a non-systematic or a very broad selection of the population just by saying there should be a complete resection possible. And if you look at the data, the one outlier is the no surgery arm of the GOG, and this is not explained by anything what we discussed today. What you can see is that the AGO has the highest survival rate for the complete resected patients and the lowest for the no surgery patients, and the opposite is true for the GOG. So the explanation why this is positive and this is not positive is clear from the data, but we have still not the explanation why the non-surgical arm of GOG is such an outlier, and this is the problem. In conclusion, we have 5 trials, 2 abrogated, 1 negative, 1 positive for PFS, but not mature for OS so far. That's a Chinese trial, and the desktop based on a series of phase 1 and 2 studies and performed as originally planned, including a validated selection process, and finally with mature data showing a significant and relevant PFS and overall survival benefit for surgery. In dubio pro reo, eligible patients should be treated in competent centers and must be informed about their chance of prolonging survival substantially if they fulfill the criteria for surgery. So thank you. Thank you for your attention. Thanks all the patients and families and the investigators, especially of surgical trials, which are really hard to run. And thank you for Rob for inspiring us to put more brains and effort into that field. And finally, we will put all the data together and hopefully find some more answers. Thank you.
Thank you, Professor Dubois, for your, I don't know how to call it. As I tell my residents every day, I start losing my knowledge because all these apparently contradictory results. And now we have some time for discussion. And I will ask Dr. Coleman to come into the discussion, and we have 2 other professors from the National Cancer Institute in Mexico to join us for this debate. And after seeing all these results, what would be the reasonable thing to do? Surgery, chemo, both, one after the other, and I would like to hear your opinions.
I mean, what is completely clear is that you cannot do everything to all patients. I mean, you have to select, and that means it depends on the quality of your center and your resources and your setting. So you should not do anything that you are not completely capable of doing it. That is true both for surgery and for chemotherapy and for all other new drugs. So first, competent center. The second is the right patient should receive the right therapy. So we have patients which are eligible for surgery, and the AGO score and others and imaging and so other could help to find out those patients with a very high chance of having a complete resection. And these patients should be offered surgery, but they should have a very high chance. So it comes together, the right patient and the right center. So if you have any doubt of not having of not coming to a complete resection, you should not do surgery. And the same is true for systemic treatment. I mean, we have also patients who are not fit for a combination chemotherapy with platinum and taxane. So we have to select those patients. I mean, for chemotherapy, the group of patients who are not eligible is smaller than for surgery, obviously. But there are also patients, and the same is true for bevacizumab. I mean, we have patients with a high risk of bowel perforations, which we never would give bevacizumab. So the art of oncology is to find the right therapy for the right patients. And in that armamentarium, surgery plays an important role, but not for all patients. I would say to less than 50% of patients. But those who will end up with this benefit, they should be offered to have that. And if you are in a center not capable of doing it, you should send these patients to centers who are capable of doing it.
Yeah, I think let me add a little to that. I think that like I said in the presentation, what's remarkable, despite the fact that they have different criteria for who is considered a surgical candidate, the survival curves over 6 or 7 years for the surgical arms of these 3 trials are very similar. So the comparator so it's not so much that the surgery that we're identifying something unique about surgery. Surgery in this setting has a definite impact. What's weird about 213 is what Andreas mentioned, is that why is the control group overperforming? I mean, why shouldn't it just be, if surgery adds nothing, why isn't it just the null? Why aren't the two curves exactly the same? Why is there a separation? And if you go into the 213 deeper and you look at only the patients who got complete gross resection, just like we saw in desktop 3, they do much better than the patients that don't get complete gross resection. But relative to chemo, the curves are just closer together. So while we select patients for surgery who have limited disease, who have good candidacy for complete gross resection, which both trials did a pretty good job with. 75% in desktop 3, 68% in 213. Those patients also have very responsive tumors to treatment. So I guess my question is whether or not we chose the right endpoint for assessing whether or not surgery is beneficial. Because in the United States right now, a platinum sensitive patient receives about 6 lines of therapy after they become recurrent. And if all those lines of therapy after they become recurrent are relevant to overall survival, it becomes very dirty, right? Because if let's say you give one patient, a platinum sensitive patient, no further therapy after surgery and chemotherapy, I mean, those patients are potentially going to do worse. So I do think that overall survival was the right choice. I believe. I still think that when you're going to do an intervention that aggressive, or it should not impact negatively on overall survival. And that was the point of doing futility. So to address your criticism, Andreas, it's a good point, but all randomized trials require a futility assessment to make sure we aren't harming patients. What happened in 213 was that the trial was so negative, if you want to look at it that way, that there was no chance it was going to be positive. So rather than waiting for maturity, which actually will probably occur next year, for 100% of the events, we would be exposing patients to ineffective therapy, which is why it was done. But I agree. I do think that there's when you raised a question about hyperselection. When this trial was initially designed, it was supposed to be bifactorial, meaning that only patients that were eligible for surgery would go through 2 randomizations, which would address your question about hyperselectivity. But as you found out with your AGO score, there's a number of patients who are not eligible for surgery because they don't meet the criteria. And so that's why and so those patients were readily thrown into this, exciting therapy for bevacizumab. And that's why it accrued so quickly. And then it took 10 years to finish surgery. So it's a difficult population to address.
Absolutely. And I mean, at those days when we both sit there and started to design these trials, which, as you said, is almost 20 years or so long. At those days, there were not so many therapies on recurrent ovarian cancer. So overall survival was clearly the one we should select by doing an aggressive therapy and not having so many options thereafter. Yep. Today, I completely agree. Today, designing a trial in the first relapse of platinum sensitive disease cannot take overall survival anymore.
Right. Yeah, you're right.
I mean, times there are changing. Yeah.
That's right. So yeah, and I highlighted it in my talk, although I didn't emphasize it. But when we wrote that trial, the median survival for that patient group, based on GOG data, was 22 months.
Exactly.
And when we finished the trial, it was 2 to 3 times longer. Yeah. So a lot of things have changed in those 20 years.
Exactly. We had the same observation.
Yeah.
But this is a plea for supporting surgical trials much more and recruiting surgical trials much quicker, because there's no way that surgery should not be evaluated with level 1 evidence in every disease. I mean, remember the LAC-C trial, how important these trials are.
Yeah.
So we have to do it. But we have to have more support from all centers that it not happens that after 20 years you come with a trial you would not repeat today.
Right. Good point.
Salim, Rosa?
Yes, ladies first. Go ahead.
Hi, Rosa. It's good to see you.
Hi.
Hi.
Thank you for the presentation, Dr. Coleman, Dr. Dubois. Dr. Dubois, it has been said that the objective of the surgery is a complete resection of the tumor and the adequate selection of the patient. How to know which is the right hospital or the right surgeon to achieve this goal? Because in surgical trials, several times the quality of surgery is the issue.
Yeah.
Mhm.
So this is a hard question, and in my country we have a certification process, a quality certification process for gynecological oncology centers. I know in the US you have similar things, and in Europe we have established also an ESGO qualification process for ovarian cancer surgery, and we have two levels, centers of excellence and certified centers, where we do some kind of quality control. They have to send in all their surgical reports of 3 years and so on and so on. So there's a little recognition of quality. In the end, it's not perfect, but it's a start. And I can only support countries doing things like that. In the Scandinavian countries, they have done also that, combined with a centralization process, and they can already show survival benefit over the country for investing in quality and concentration.
Thank you.
Salim?
Yes, congratulations for your presentations. I mean, we have some fantastic answers for some of these questions, and I think that the principal thing, as Dr. Dubois said, is the correct selection of the patients to achieve the complete resection. But one of the questions that we always have, for example, when we are discussing these cases, is what do we have to do first? Do we have always to give the chemotherapy at the beginning, and then we evaluate if we can achieve the complete resection? Or in some cases, should we start with the surgery and then give the chemotherapy?
It's a very good question, but we have no data about that. So we have there's only one retrospective analysis on neoadjuvant chemotherapy before surgery for recurrent ovarian cancer by Scott Eisenkopf, and he found a negative impact of that approach. But that was retrospectively analysis, and there's not one prospective trial on that. So we cannot say. I mean, we know from primary treatment, we know that this is an approach for patients who are not good candidates for complete resection initially. But we know also that the role of complete resection in interval debulking is much less prominent than in primary debulking. So a complete resection after chemotherapy does not mean the same impact as we have it primarily. So
Yeah.
I think we cannot just extrapolate on that. So we
Agreed.
have no data on that.
Right, and remember the EORTC trial was essentially that. It was addressing that question
Exactly.
prospectively, and that was closed for futility.
Yeah.
All this information that you showed us is related to patients with a platinum-free interval of, in general, more than 12 months. But what should we do with those patients that recur between 6 and 12 months?
I mean,
Should we go to surgery?
I think in both studies, the inclusion was 6 or more months. So we have these patients in also. The majority had a longer treatment-free interval. I mean, we are currently Bois in the US had a very nice publication where Rob is part of it. We have another one now with the ESMO-ESCO consensus. We are not so stuck to the calendar anymore in our treatment decision. So I would not principally say you have to count exact months, but I would not expose a patient to such an aggressive approach if I have not the feeling or the impression that this patient has also an impact on therapy. So if I have a patient coming directly out of frontline treatment, uh, the gain for these patients will be minimal, and in that patient, I would in doubt not suggest the surgery.
Right, and remember, if the biology of the tumor is chemo resistance, surgery is not going to impact that patient.
No, that's true, unfortunately, with one exception, that is the low-grade tumors.
Right, yeah. I would agree with that. Yeah.
Okay, there is some questions from the public that are online, and probably the good selection is how are we going to ensure the complete resections before the surgery. I mean, we know the OVA studies, all these series, but Dr. Dubois, could you explain how to achieve which studies should we ask for to do the evaluation for this approach?
I mean, we currently use on one hand the AGO score, which is a rough instrument sorting out some patients, and then we do imaging. I mean, and it depends a little bit on the resources and the experience you have. I mean, in Denmark, they have excellent resources and experience with PET-CT. In Belgium, they have excellent experience with diffusion MRI, and in other places, they have excellent experience and very skilled people with a CT scan. So whatever you use, I mean, you should use modern technology with high resolution imaging to rule out patients who, in the end, will not have a complete resection. I mean, in our institution, we don't use PET-CT for that, but others do it, and it depends a little bit on what your situation is. Laparoscopy can, in some cases, be of value, but in our experience, is not a general approach. In recurrent ovarian cancer, laparoscopy is not so easy. You have adhesions and all that. So this is a little bit more difficult than in primary situation, but in doubt, I would do it. I mean, before I open up the whole abdomen, I would try to get a picture. But to be honest, in patients where I'm in doubt, I would not do it.
We have one question from the audience, and they ask, how would you confirm the complete resection of the disease? Confirmation of complete resection.
Yeah. So I mean, I can do it with my eyes for myself. But in a study, it's a different thing. You can never guarantee it. I mean, there's no way to guarantee it. But centers who have such an energy and enthusiasm to run a surgical trial, these are usually honest people. I mean, these trials are underfinanced, they are underpaid, and you have to have a lot of enthusiasm to work for years and years and years to do such a trial. So personally, I first trust these patients, these centers. And maybe some patients are in between who may not have a complete resection. But we have had a manual for the surgeon how to approach every area in the abdomen. And also others have published very systematically ways to approach everything. And we did not allow laparoscopic resection. We did not allow Pfannenstiel approach and so on. I mean, this is clear. With a Pfannenstiel approach, you cannot really evaluate the spaces behind the liver or so. But at the end, you have to trust these people.
Yeah, I'll add to that the we've tried to do studies where they required a post-operative CT scan to confirm a complete resection, which were terrible. You didn't know what was post-op change. Sometimes tumors do grow after surgery, and so it was very difficult to actually come up with a confirmation. We have taken photos intraoperatively to confirm that the areas that were addressed, it had no evidence of disease. But I think it gets back to Andreas's point, is that listen, call a spade a spade. If you're leaving disease behind, you're leaving disease behind. I mean, it's okay. It's not a failure. But since we don't have perfect tests to identify who's the patient you're going to be able to do a complete gross resection on, you just have to use your best judgment with some of these tools to help identify narrow the funnel of patients that are coming to go to the OR.
We have recently published a small series where we took liquid biopsy after surgery, and we could confirm in a small series that complete resection also leads to clearance of tumor cells in the peripheral blood within 48 hours. So I mean, we are working on this further. So that could be that if it is confirmed in broader series in many other centers, that could be an approach to get a little bit more objective impression of a complete resection or not. It could be, but currently in the routine, it's not established.
Another question is, how would you consider a suitable center to treat these patients? Is it about the value of
it's training, education. So numbers is also important, but numbers is not the first. You can do many times, you can do things wrong. So numbers alone is not enough. You have to have a good education. I mean, I don't know how the situation in Mexico is. In the US, as in Germany, we have a established program, education program called Gynecological Oncology over 3 years. And so this guarantees at least some qualification on that. And then you need enthusiasm, and you need dedication to that. And so if you have the possibility to visit Rob, to visit me, or to the Mayo Clinic or the Memorial or Bristow or here Christina in London or in Giovanni in Milan and Berlin. I mean, these are really world-known excellent centers, and a visiting program always broadens your perspective. I mean, all of us in these centers have 50 or so persons per year in the operation ward, and there you can really, I mean, you can see how good you are, and you can see what is possible.
Yeah, many of us also, if you're learning to get some experience in places that don't have those types of educational resources, they'll do multidisciplinary team approach. So they'll bring in, other surgeons to help, knowing what the goal is. But it's important to understand that the people that are part of your team understand ovarian cancer, that they understand what the intent is, and they can provide some education on the surgical skills.
And this is a very important point. The problem sometimes when you put multidisciplinary teams together and you have a GI surgeon on board, and the GI people stop their surgery when they have a peritoneal carcinomatosis so they never go for what you need to go for an ovarian. So to read the disease and to understand the disease is I mean, I always say our fellows, what is the most important instrument of a good gynecological oncology surgeon? And most of them say your fingers, and I say no, it's brains.
Exactly. I love it. I love it.
I think Rosa has a question.
Yes, Dr. Coleman, why did you choose the surgeon criteria on which patient had the possibility of cytoreduction instead of a prognostic model like other studies?
So it's a good point. We at the time, remember this is 20 years ago. At the time, we didn't have any validated tools. So, but we knew that complete gross resection was an important endpoint. And so what we did is, as Andreas mentioned, the gynecologic oncology community in the United States is all fellowship trained. So so the standardization is really from the standpoint of the participants from centers that are doing GOG trials and also are trained as gynecologic oncology surgeons. So we felt that that each of these individuals, since they have potentially varying skill sets, that we would allow them to choose the patients they felt they could resect. So the idea was, so the endpoint was complete gross resection, just as Andreas mentioned, but we didn't restrict it to specific criteria as long as they met the idea that they could achieve a complete gross resection. So a little bit of trust on the surgeon's standpoint to make sure that they selected patients who had disease that wasn't carcinomatosis, that didn't have parenchymal disease outside the abdominal cavity. And if they had parenchymal disease inside the abdominal cavity, that they were able to resect it so that they could have a complete gross resection. So that was the reason for why we did use that criteria.
Okay.
Para nuestra audiencia, por favor, manden más preguntas. Aún tenemos tiempo. Salim?
Yes, I have another question, and I think this is a small group, but in the every day we can find this kind of patients. What about the patients who have a limited disease in lymph nodes? I mean, do you recommend in those patients go for the surgery? Because there are some theories that they say that probably the chemotherapy is not going to go to the lymph nodes, or probably just give even radiotherapy. What do you think, or what is your experience in this kind of patients?
Well, I mean, first of all, whether a lot of people call the lymph node area the watershed area, but I think that most people feel that chemotherapy does address those points. That's not an isolated site of chemo resistance. I wouldn't use that. That's too broad of a term. I will say though, I didn't show it in the slides, but we did do a analysis of patients that had one or two sites of disease or one site of disease. Most of those patients that had one side of disease had lymph nodes. And so they would go in, and so easy, and they had a very high rate of complete gross resection, like over almost 90% complete gross resection, because they were very easy, low to take out. And again, it basically showed what I showed you with the complete gross resection patient population. It's very similar, that the two curves essentially were right on top of each other. So it led to very high rates of complete gross resection, but it didn't outperform the chemotherapy, at least in our trial. But it was much, much better than the patients that had more than two sites of disease.
So yes, I would agree that I don't believe that lymph nodes are not chemo sensitive. I mean, this is not my observation. I know that this has been discussed a few years ago, but I don't believe that. Anyhow, having said that, on the other hand, I agree that complete resection in patients with lymph node metastasis only is very easy to achieve. And I would say it's the easiest part of ovarian cancer surgery, because in contrast to cervical cancer, the lymph nodes are easy to remove from the vessels. I mean, in cervical cancer, they're sometimes really nasty on the vessels and adhesions and everything. But in ovary, it's usually not so difficult. So these are good candidates for surgery. And if they're out, they're out. And and then they receive the systemic therapy. This is not, this is not the operations that do pathology and complications are not the lymph node removals. This is the extended bowel surgery, which really bowel and pancreas surgery that makes complications, and lymph nodes is easy to operate. So I would always evaluate the patients whether she's not a good candidate to remove the lymph nodes if they are metastatic.
We are coming out of time. So Professor Dubois and Professor Coleman, what would be your take message for today?
I would say don't believe Rob.
I was just going to say the same.
and admit that one outlier does not falsify a whole principle. And no, hopefully when our paper is out, we can put the data together and further look on it. I have no really sound explanation, and I think Rob does not have also a sound explanation on that. We see there is an outlier, but we cannot ignore that we have very proper performed data who at least suggests that there is a potential benefit. So we should not throw that away.
Yeah, what I would, and I think if SOC1 comes back as a negative for OS, I still think that the most impressive observation between these three trials is that the surgery arm performs very consistently. So, like amazingly consistently. So I think what it provides for future, benchmarking is that we can see what a population in now, several hundred patients, that surgery is going to perform at a very consistent rate. And so we can use that as a place to start launching other programs, potentially new adjuvant therapies that consider that. But now we know where the baseline is. And I think that that's very important. So the trials are very consistent with that parameter. Sorting out, the nuances of patient characteristics and stuff will be very important to understand whether or not these more targeted drugs will actually, provide even better benefit, more benefit, on top of that surgical intervention. But I do think that and I'll echo what Andreas said, because it's so important, is that these trials need to be supported. And that's the only way we're going to continue to address these questions.
In addition to this, I would like to tell our young fellows and our residents and our young UIN oncologists in Mexico that we have to select the cases, we have to try to achieve complete surgery, and we should not forget to study and to have commitment for the surgeries. And I don't know, Rosa or Salim, would you have anything else to add?
No, you say I think that the best thing or the best part of this is to know the correct selection of the patient. If you select correctly, you are going to have a good outcomes.
But it's important to notice that in our country, the access of PARP treatment and antiangiogenic treatment is very low. We should take the best of two studies and use the best of our country.
In our country, in our institutions, we have different systems in Mexico, and some people may have access to PARP inhibitors, and some others will not have access to the bevacizumab neither. That would be a problem also. So I just want to thank Professor Dubois, Bob. I thank you for your kind presentations, and I thank you for accepting our invitation to this meeting. And hope to have you here sometime when the pandemic allows us. And
hopefully,
I thank you.
All right, guys. So good to see you, and thanks for your invitation.
Okay,
Andreas,
bye.
be well.
Bye.
All right, bye, guys. Bye-bye.
Mm.